Two lunchtime sessions. This one is sponsored by Envois, Bracing for Impact. Really going to try to get into unloader bracing and also get into DME ancillaries and how to bring this to your practices. You can see, as always, Brian has many more and smaller titles than I have, so it's good to have him up here with me. I'm going to go through the clinical rationale for unloader braces, introduce a bit of the DJO Envois line, and then turn it to Brian, talk about philosophy, strategy for ancillary revenue. We have microphones here. Certainly come up to the mics and ask whatever questions you might have. This topic's important because osteoarthritis is exploding. You can see the data, 650 million patients. You can see the numbers of patients who have arthritis and are trying to manage this above 40 and trying to stay extremely active. We know that there are many different risk factors. We've talked about them all morning and we'll continue through the afternoon battling some of these risk factors. And the questions here is to identify those treatment gaps and to see how bracing may fill some of those gaps with and for our patients. I think it's important, and Brian's going to get into this just a touch as well, and we have previously, but when we think about it, there are only a few ways that we can truly unload the joint. And I think if you're going to be mindful about when and how you might want to use braces, we also need to be mindful about all the other things that we do conservatively to maximize. So we have that one slide and skip over it on the panels, but it's important. And weight optimization is a critical part of unloading, and rehabilitation, core to floor rehabilitation, to dynamically distribute those forces on the limb are very important. So it's not just tunnel vision, laser focused on the bracing. I'm often having to sell this concept to the patients. And so I'm going through this over and over again with my OA patients. I'm using medications and or injections to reduce inflammation so that you can rehab effectively. I'm really buying them in on these major tenets of unloading. And then I think in general, when you're talking about giving people something non-operatively in the office, whether it's an unloader brace, whether it's a sleeve, whether it's medications, etc., we are really trying to test them and get them in line with our treatment thoughts and philosophies before we're doing bigger and more dangerous things on them. And so establishing compliance, making sure they actually try and do and report that they do or do not like your brace and why, and we're establishing a rapport, getting some trust. And so I think that just philosophically, those are good things that help me. And frankly, none of us want to be non-surgical OA, psychology counselors, but we wind up doing that all day, every day. And I think if you're mindful about these concepts, then at least it could be more fun and rewarding, and we really can affect change for our patients. I think we all think about and know how bracing can be useful for osteoarthritis. When we're talking about malalignment, we're talking about overload, we're talking about all those other factors that get you into this vicious feedback cycle of painful dysfunction. And so there are several different areas where you can hit on this, taking load off, improving stability, etc. And there are different options for unloading braces. The DJO line, as we'll go into and talk about, has two options in particular. One where you can push that limb out of varus or valgus, and the other, utilizing those straps, is more of a pull mechanism. And so you think about designs of brace and the actual frame and construct versus where and how you put those straps, and you can do different types of unloading for different types of patients. Here's their broad platform. I think the team likes to say that the best brace is the one that the patient's going to wear. And so you can think about and try to at least have a framework in your mind to conquer this portfolio, and the team can help you. But you're thinking about activity levels, duration of wear, rigidity. You're thinking about early or no OA yet to mild, and then really most of the focus here is in moderate to severe OA. And then we're thinking about some of those braces that we might use to unload our elite athletes on the field, such as the Defiance, and then other braces that are more comfortable and maybe better for our recreational weekend warriors, such as the newer Rome. And so so we really have these launches that occurred this year. So go check them out at the exhibits if you haven't already, and we'll kind of give our thoughts on them as we go through. One of the nice things about DonJoy, at least here, is that they're trying to put some evidence behind the bracing. And so, orthopods like these types of heat maps. You can see with and without defiance. You can see that more green means increased joint spaces. And so at least we are starting to understand how and why these braces may help us to unload. Similarly, I think this might have been done at Rush, but this is looking at a patient. So look at that right knee and look at the varus thrust throughout the entire gait cycle back and forth, and then you can see them in their brace, and you can see while it's not completely eliminated, it does pass kind of our visual test, and also you can see on the left that you can follow the different parameters, and you can see improvement in those parameters. So again, if we can mitigate their varus thrust, we can reduce their sense of instability, and we can try to affect change when they're cutting, pivoting, and going back to their activities. Now that's all well and good in the gait lab, but how does this work in the real world? And so this is just a sampling of real world patients with and without braces, and you can see reductions in pain scores, reductions even in a sense of stiffness, interestingly, and most importantly, that improvement in function. So, of course, it's multifactorial. The type of gains that these patients want to get from their non-custom custom brace, but it's good to see that actual clinical data looking subjectively and also objectively that we're making these gains. Just a few more thoughts about bracing. I think DJO's led the way looking at some of the data on protecting and preventing ACL injuries. And then these are two of the highlights that you'll see over and over with their platform that I just wanted to look at. So the first is their study on 4 points of leverage. And so the bottom line here is that they've shown that they can decrease ACL strain by at least 50%, reducing rotation compared to unbraced and sleeve groups. Also, sleeve braces can help with proprioception, postural control, patient confidence, etc. And then I think the other concept when we're talking about our acceleration, decelerating, landing, jumping athletes is the force point. And so basically what you can see here with the brace, we're trying to get these athletes to pre-position in safer positions. If you land stiff in valgus with your body out of control, you have much higher lever arms for issues. However, if you pre-position and you land broad-based inflection and you have this dampening of their extension or hyperextension, that can also help to mitigate risk. And so the force point hinge technology really works to increase those flexion angles, reducing shear forces and reducing strain. And then this also just came out. I think we've seen in general in the NFL the reduced utilization of bracing. And even at the NCAA level, I'm fighting some of the coaching staff and fighting some of the athletes who really don't want to use braces. This is data just looking at 1,400 non-braced versus 154 braced, and the performance metrics were the same, and the non-braced groups had more injuries. This is OJSM. It's reasonable, and we have a paucity of evidence, and it's a mixed bag. So obviously we need better data to support this, but at least from studies like this and the prior ones that have been out there, be mindful of the thoughts about prophylactic bracing, the risk to linemen and MCLs, and I don't think that these concepts should go by the wayside. I'll close with just a few case examples of when I might use braces in my practice. So here's a pretty typical one. A 50-year-old male, medial pain, activity-related swelling, BMI is 36. You can see the mechanical axis demonstrates varus. And so for me, this is really that principle of non-operative management. So I'm going to go through everything. I'm going to use medications and/or injections. I'm going to use a sleeve brace combination. Maybe, Brian, I'll ask you, how do you sell the brace to these people in the clinic? Like, when do you tell them to use it in a medial arthritic like this one?
Yeah, some people have this vision that it's even protective, but I just say, look, when it's on, there is some adaptive phenomenon that the more they use it, the more they seem to have an effect. But I basically say you don't need to wear this all the time. There are certain activities that you might enjoy doing, but suffer from medial-sided knee pain. So I use the unilateral, I use the Rome brace, which is a pull brace, which is a unilateral upright brace. It's very well tolerated. It's not bulky. It's not heavy. And when they wear it, it generally has a positive impact. When they take it off, there might be a little residual. That's been looked at too. But it's really while they're wearing it, when they're active, and that's what I instruct them. It's just one measure on top of a holistic approach that you alluded to.
So clearly, strategic brace use, I think, is very important for adoption for these patients and understanding the role of when they might want to take load off of that. Are you still finding in your experience that it's basically splitters? They either love the brace or hate the brace? Or do you think that there are some iterations here where they can meet with the reps, kind of format it, break it in? Like, what's the concept now?
I think there are those who do love it, and they love it it's probably working in a variety of ways. Just feeling like they have something on the limb helps them, gives them secondary stability, even independent of any potential reduction and adduction moment. And there are those who are like, it didn't do a damn thing for me. I have a long track record with braces just because we were using them for a long time as a predictor for success with HTO. So I have a good gut as far as what I think will happen because we have been using them for years. Now I'm actually using it more as a function of treatment, for prolonged treatment, just to keep people out of the operating room, because this is a population that, look, they're not ready for an osteotomy. They're just, not everyone needs to be hit with a stick of dynamite, right? So there's the bulk of people are middle ground patients that you and I never have to operate on. You just got to give them enough to nudge them to a place where they're not symptomatic. So that's sort of that middle ground patient. I don't have too many people that hate it. The braces are so good now in terms of how they fit for most people, barring, some real real anomalies in terms of how people are built. But generally, I don't have them hate it. They just may say, look, it's not doing anything for me.
I think gauging compliance to their initial bracing and even getting them to understand that transient offloading, which helps in your surgical discussion later on for introducing things like HTO. Here's another patient. This was a D1 athlete. This was a meniscus repair and a cartilage defect. So maybe talk to us about how you're using braces in this patient. Yeah. So do you have two different braces, or are you just using a post-op brace and then not transitioning, or what do you do?
Years ago, I helped, when it was DJO, not known as a novice, I helped them with an unloader post-op brace, which I thought was the greatest idea ever, but it just didn't take off. So unfortunately, I use a hinge knee brace, and then I switched to I just like the single upright mainly because it's lower profile and patients like it better. So this is it's not out of the box thinking, but it's not first on your radar as one more adjunct to protect the medial compartment. It may not change my willingness to load them sooner, but with any reduction adduction moment, you're probably protecting the medial side, and this is one obviously with a repair that we could argue that whether or not the OA graft needs it or not, but I would argue with a meniscal repair, most of us with load rotation would prefer not to load these kinds of repairs high in a significant way early on, and I would say it's that transition of non-wapering or heel touch wapering to full wapering where you would feel more comfortable having a brace. The other thing is it might provide a more pain relief post-op as well.
And this patient had neutral alignment. So is there a role for unloading situations like this, even in neutral?
Great question. So, if you look at reductions at adduction moment, generally speaking, if they don't have too much varus but enough varus to neutral, those are the ones who are going to see the most dramatic benefit. But I also think the brace works for other reasons, just the physical contact and the proprioception and so forth. So I would say no problem putting it in someone who's in neutral. You might get better. You might even like it if you're in a little bit of net valgus, but probably not for the reasons of unloading, my guess is.
Yeah, I'm also worried about this patient, and it's going to be a long enough road. I need the bone of the allograft to integrate and heal. So they're going to try to race away with this protocol in that mid-range, and I think that just having them have something that there is tangible that they can remember every day while walking around campus, etc. That they have a brace and ideally taking load off them as well is just helpful. And then my last slide here. This is just the classes. This is a D1 football lineman. He had a BTB. He had a pretty complex meniscus repair, and so I guess just in general, maybe with these football athletes going back to sport, I mean, obviously we have prophylactic bracing quite accepted for one side of the ball, not necessarily for both sides of the ball. This guy, you're putting him in the Cadillac of braces when they go back.
Yeah, I mean, look, there's one place, like you showed that study from 23, there's one place where braces it becomes hard to argue that it doesn't have an impact, and that's for linemen. And wearing some type of double upright brace. I mean, there's a reason colleges invest in that. I don't want to say it's a standard of care, but I would say it's pretty darn close to it.
And then when you have a skill athlete, lastly, so our wide receiver,
Yeah.
for example, is a good example, discontinued his brace after his ACL before his breakout game at Colorado, for example, so now my team has a bracing conceptual problem, with the skill athletes. How do you deal with that?
So I have more experience in the NBA, and I will tell you, you can get an NBA athlete to run up and down the court with a brace on if it's well fitting, and they like it. Just watch a few games, you'll see how many people wear braces. That my hypothesis would have been that they wouldn't tolerate it, but they do tolerate it. So we have so much arthritis in the NBA, especially lateral compartment osteoarthritis, and many of them get some benefit, because we're trying to keep them out of the OR and just get them incrementally better. So it's surprising how well it's tolerated.
Excellent.